This is the session on data governance platforms and linkages, data strategy. So could the panelists please come and take a seat? I think because we don't have slides, because we want you to be engaged, we have one presentation, I think, that has some slides. You can sit right here and you can present your ideas from here. That'd be great. So I'll introduce myself. As I said before, I was the co-chair of Canada's COVID-19 Immunity Task Force. You know, my scientific interests have come a long way. It was HIV for decades. and I'm still very much involved in novel HIV prevention trials in South Africa for young women who are at extremely high risk of HIV. I'm keen on global health equity and on translating science to the general public and also to policymakers and decision makers, and to capacity strengthening in low and middle income countries and advancing women in science. So I was chief scientific advisor to UNAIDS for 10 years, which gave me a really global perspective on knowledge translation and policy development. And I led the development of the Good Participatory Practice Guidelines for clinical trials for emerging and re-emerging pathogens for the WHO R&D blueprint, and you can still see it up on the website, and I think it's been being used. Okay, and that one was in 2016, not knowing, obviously, that less than 4 years later, we'd have an emerging pathogen, and we'd have to be thinking about community engagement and good participatory practice in research. So I'd like to introduce our panelists for the session. We have Laurie, who's going to be joining us online. And I think, Laurie, we'll have you go first after I finish the introductions. So Laurie Beach, she wasn't able to make it today. Hopefully she'll make it tomorrow, because what's happening in Nova Scotia? Another snowstorm, another big snowstorm. Yeah, BC needs it, right? She's a clinical biochemist and head of chemistry at Isaac Walton Killam Health in Halifax, where she provides clinical service in laboratory medicine, specializing in pediatric and maternal care. And that includes prenatal biochemical screening, newborn screening, core automated chemistry, point of care testing, and mass spectrometry and specialized chemistry. She's an assistant professor in the Department of Pathology at DAL and is the division head of public outreach and communication for the Canadian Society of Clinical Chemists. So we'll get to you in a moment, Laurie, but we're looking forward to hearing from you. Next, we'll hear from Sheila. We already met Sheila a little early, so I won't dwell on your bio, but she is head of epidemiology and surveillance at the Canadian Blood Services. David Buckridge is a professor in the School of Population and Global Health at McGill, and he directs the Surveillance Lab, an interdisciplinary group that develops, implements, and evaluates novel computational methods for population health surveillance. He's also one of the scientific leads for the COVID-19 Immunity Task Force, the Chief Digital Health Officer, which sounds interesting, at McGill University Health Centre, a medical informatics consultant to the Quebec Institute for Excellence in Health and Social Services. And this I found really interesting. I looked it up. He's an associate member with MILA. Now, I don't know if you've ever heard about MILA, but it's the Quebec Artificial Intelligence Institute. It's a community of over 1,200 researchers who are committed to advancing artificial intelligence for the benefit of all. It's the largest concentration of deep learning academic researchers globally. That's what the website says. Then we have Harriet, who's joining us, Harriet Ware, who's a health data scientist and biostatistics professional. She's a project co-lead for SeroTracker, so you're going to get into some more details about SeroTracker, the dashboard and data platform that was supported by our task force and that supported us, and partnered with the WHO, which tracks SARS-CoV-2 and other infectious diseases. So during the pandemic, she built, I love this, reproducible pipelines for serosurvey data analysis and synthesized results from the WHO Unity studies. She's also the co-chair for HEMANET's Data Protocol Standardization and Sharing Working Group. So we actually just got a message that Lori is not online yet. So Sheila, why don't you start? I think you're the one that has some slides, yes. So why don't you start? Mandate was 5 minutes max each, so we can have a panel discussion and then.
Yeah, so I'll pack as much as I can into my 5 minutes here. I wanted to just tell you a little bit about our experience with data linkage, which is, has gone over a long time. We haven't done a lot of actual linkage yet. So you've heard about our blood donors. I do want to make a clarification from this morning. What we were talking about this morning were plasma donors. Plasma donors are more likely to be female and male. They are a small proportion of our collections. The vast majority of our collections are whole blood donors, and their age and gender is very similar to the general population, from 17 up to about 65 or so, and we tend to have fewer that are older. And we have, in our SARS-CoV-2 seroprevalence, we tested over 1 million samples. We are now finished. And we have been testing since very beginning of the pandemic right through until December of 2023. So 3 years and 8 months of testing there. But what I want to talk to you about is our adventures that we've had so far in data linkage. So we really want to gain more insight into our data. We do not have questionnaires for our donors, only for our operational side, but not a research questionnaire. So we don't have good data on vaccination history, and we don't know what their PCR testing. These are just fairly critical pieces of information for interpreting seroprevalence. So, we have embarked on data linkage at ISIS, and we actually have a contract signed now, so we're very close to being able to do it. Now, what they would be able to do is to link the donor data with vaccination and PCR testing, and then they would put it into the IDAV portal, which is accessible to the researchers, to a very small and select number of researchers. ISIS have special legislation in Ontario which allows them to do that sort of thing. So that one is very close. We also are attempting to do something along those lines in BC. In BC, we would do the same linkage, but it would be housed in the BC CDC, because they do not at this time have a way to make a portal to external researchers. So what we would do is we would perform the analysis, for example, on the ISIS IDAV portal, and then share the programming with BC, and then they would run it. Or it could go the other way around. BC CDC develop the program, and then we run it on the IDAV. And either way, you put together the results from the two provinces. And I should also mention that the reason why BC is not done yet is because we were overloaded in our legal department, and I told them to stop doing that. So because otherwise I wanted to concentrate on getting the ISIS through. So that's why we've made progress with ISIS, and then as we get that organized, we will go back to the BC. So this way we will have, in total, 60% of our blood collections in the study would have linked data. And just, this is one of my last slides here. I'm getting close to the end here. What I want you to see is that there are multiple steps in trying to do linkage, and this is why it's complicated to do. So first of all, you need research ethics. If you don't have informed consent, they can waive consent under certain conditions. there has to be a privacy impact assessment. But in our case, and I think most commonly, there will be two. So one is the privacy impact assessment of Canadian Blood Services, because we are providing the donor identifiers to another organization. Also, there is a privacy impact assessment from ISIS, because they are sharing certain data with us. So there's two. And in our case, we do ours before we do the research ethics. So we do privacy impact, then you do ethics, then you go to ISIS and they do their privacy impact. Then you do the contract, then there will be a data creation plan, and then they do the linkage. If you don't have good data, and if you don't have the donor healthcare number, then it would be hard to do the linkage. So you have, when our donors come in, they provide government ID for their first donation, which we write down their full name and their date of birth. So we have very good data, but if you don't have that, it's very hard to do. So there are some certain strengths of data linkage. It will permit access to accurate data. It will expand the breadth of the data, and we will have the opportunity to evaluate longitudinally in certain cases. Other important limitations are, like I say, you need to have identifying data. The administrative data may not be sufficiently granular. It's not like doing a clinical study. It also, you will not have data on people who don't go to see a doctor. So, so there's certain people that are not captured in there, and you don't get data on risk factors. So some limitations in what you will get can be more difficult to analyze, and it's the logistics of actually doing the linkage are very complicated. So at Canadian Blood Services, we propose to reorganize what we do to better facilitate public health research. So that would be our donor research. We want to do chronic disease and infection surveillance through having a health and lifestyle questionnaire first, for a large cohort of our donors, those who wish to be involved in research. And then we will also have a way of selecting blood samples and have data linkage set up. So by having the three together, we should have very comprehensive data on our blood donors, which can be leveraged for a pandemic in the future. And I thank you for your attention.
Sheila. Do we have Lori online? Okay. Lori, welcome, and we're sorry you can't be with us today, and hope you can make it for tomorrow. We're interested in hearing about your experience with antenatal surveillance.
Sure. Hello, everyone, and welcome. Hello from snowy Nova Scotia. I do have one slide. I don't have to share it, but it says that host has disabled, just so you don't have to look at my face the whole time.
Go ahead, I say. Is she allowed to?
If I'm not allowed, it's fine.
I don't know, can she share it? Handling the... You have to make her a co-host. So
if it's not possible, we won't worry about it. Oh, I can. Well, look at that. They're just that good. I gotta say that tech team is right on it. Marvelous. Okay, so yeah, if anybody else is wondering how a clinical biochemist ended up in this group, you're not the only ones. Sometimes I wonder how I got here. And I'm really glad to be part of the group and to be learning as much as I possibly can as we go. What I wanted to share with you is just a little bit of a Nova Scotia experience, because I think that other areas of Nova Scotia and certainly Nova Scotia Health have partnered with other aspects of serosurveillance. But what I was involved in was the antenatal serology studies. How did I get in the midst of it? It was a linkage of sorts. There's the Maritime Maternal Serum Screening Service, for which I'm the medical director. And so that was, we have the samples. We also had brought up the ortho anti-spike SARS-CoV-2 assay for clinical use in MIS-C investigations, because the IWK is the tertiary children's hospital. For our clinical, especially microbiology colleagues, their prioritization was really around PCR testing, and completely appropriately. So when, this opportunity came up and I started speaking with some of my colleagues in microbiology, as they say on the East Coast, they told me, fill your boots, like, go for it. So I did. In terms of data, I wonder if in part, I'm on the panel because there was so much more we could have done in Nova Scotia with data linkages. And unfortunately, just because of how quickly we needed to be able to move things along, and because of a lot of what was already raised in terms of making sure that we could get through ethics approval, we were really limited in what we could actually use. So the data that we collected as we did the serology results was also the age of the women that we collected and the first 3 digits of the postal code. And even the postal code was like, ooh, we might not get approval to do that. On data that we missed, that's on our existing requisitions when we do prenatal screening, for example, was weight, ethnicity or racial origin, gestational age, and some ultrasound measurements. We could have done 1st to 2nd trimester changes in serology status, but that just wasn't possible at the time. Any pregnancy biomarkers that might have been part of that testing, the screening results, other things we would have loved to do, but it would have required a new request, would have been things like vaccination status. That is not part of a prenatal record in Nova Scotia that I can just pull. Any COVID exposure history is not available. Linkage to pregnancy outcome information. We do have a great database in Nova Scotia called ATLI. And in the future, especially if we're looking at prenatal specimens or antenatal specimens, it would be wonderful to figure out how we can link up some of those. And so as I was reflecting on this, you know, if we have the opportunity through HemaNet to set it up in a way that is going to get us exactly what we want, then wouldn't it be great if we could do some key things like engagement with populations, especially special populations. Our Indigenous population here, for example, before collecting any data, absolutely needed to do that engagement. It would be great, especially in Atlantic Canada, and what I'm hoping for with HemaNet and the Atlantic area is that we can have that engagement with additional provinces so that we don't have to do Nova Scotia by itself and New Brunswick stand up their own and PEI and Newfoundland and Labrador, but we can have an Atlantic solution. Unfortunately, we weren't able to report back on any data, even though we had the specimens about New Brunswick, for example. Engagement with information systems, there is so much data in the information systems, but it's a matter of figuring out how we can access it and do it in a way that's safe and everything else like that. And then I'm just thinking about strategic partnerships, that is especially with all of the people in the room there with HemaNet, because we are a resource challenged area. And so if I can help represent a very resource challenged area as we build HemaNet, then I'm very, very happy to do that. And one of the last things that we recognized that we needed was dedicated or more specific infrastructure for this. It was very quickly realized that continuing this in the clinical area, for example, in Nova Scotia, was just not going to be sustainable, whether that was because of, you know, budgeting resources, human health resources, all of those sorts of things. It was not sustainable to continue doing. And the last thing that I just wanted to raise in my hopefully not over 5 minutes was I think one more area of data that we can consider bringing into the mix at the risk of scope creep is as we're figuring out what the HemaNet network is going to look like and how laboratories or areas that are doing testing are, for example, going to be standardizing either the tests themselves or other elements of it. I would be interested in also seeing how we can standardize how we stand up the quality management around those tests. If there's a standardized way or a common way for HemaNet Canada that we say, this is how we manage the quality framework around the testing that we're doing so that it's common across the country. That's it for me.
Thank you, Lori. Lots of great ideas there. Really like several presentations have come with HumanNet, we could do this. We're starting to get a vision for where we could go. Now, not to be a downer, but can David tell us a little bit about some of the governance challenges, some of the data challenges faced by the task force, how they were overcome, what we would do differently?
Thanks, Kate. And I think, so my role in the context of the CITF was as the scientific lead for data management analysis. And so I think a lot of our thinking went into kind of, or a lot, as I was seeing externally, was creating this data bank to support data sharing. But I think it was less about infrastructure building than about the culture enabling processes to support data sharing. And you know, we started out with this goal of enabling rapid sharing of high quality data to support, and results to support, and I'll make a distinction between those two in the sense that data are really those individual records you're getting from doing studies. Results are those aggregate measures or insights that come from the research. We focused a lot at the outset on data sharing, and I think what really became clear over the first few years of the, well, it was a long pandemic, but after a year or two was that it was really the results that were the time critical piece, because it was going to take the kind of pace of science to get the data moving. I think it's still highly valuable, but that was sort of one issue. So, you know, we had to address a lot of elements, as Kate was saying. There was the data governance piece, and we went very deep down that lane at the outset to create what's called a data governance framework, which I think was a really important step because it laid out under the law what were the authorities for us to collect data, how we could use data, and who we would permit access to those data for what purposes. And that became the framework for all of the data sharing agreements we put in place and allowed us to sort of have a sense of where we stood when it came to questions about data access, data use. And so that was very important. We also spent some time focusing on data quality. And we had really, you know, the CITF, the task force, we had access to really a great range of experts who leaned in right from the start on helping to define what we called common data elements, which were, you know, guidance to investigators that when they're collecting common types of things like age, like vaccine history, to, unless you had a really good reason to do it differently, do it this way, please. And that, as you can imagine, helped when we brought the data together to make it comparable. We also build out some real expertise in terms of data management, to the folks that are here on the team. I won't call them all out, but Ahmed, Hannah, Tanya, you know, who really built that expertise in helping investigators record their data the right way, send it to us, and then also helping to harmonize it. I would say the challenges we had, you know, the first one was timelines. That was the challenge everybody had, but boy, wouldn't it have been nice if we had some of these things ready at the start. And it wasn't. It literally was building the plane as we're flying. It was challenging to maintain alignment of priorities and governance and operations because things shifted quite quickly in the pandemic, and appropriately the task force was shifting goals. But when you're doing data infrastructure, data governance, it's kind of hard to turn left suddenly. And so it was challenging. So for example, those common data elements, we had to do multiple revisions of those to reflect that, you know, the vaccine arrival, hotspots, other sorts of things we wanted, different types of information. And so maintaining that compatibility was a little challenge. We had some challenges too with serology data interpretation because of the changing assays, comparisons across venous dry blood sampling, you know, questions that persist today, to be honest, in terms of, you know, how to really interpret those. I think our successes really were data governance, that, as I said. The fact that we did think about results analysis and reporting separately from the data and started to build up some processes for those, and ultimately leading into this routine report we sent to the Chief Public Health Officer, which I think was really primarily based on those results and also initial reports directly from studies. Our research data bank, I think, is also a really good start in the sense that we've defined a lot of those processes that if we want to do this again, I hope we don't have to, but I'm sure we will. We'll have data use agreements in place. We'll have core data elements defined. I mean, they'll have to shift for different, you know, conditions and viruses and so on, but, or other organisms it might be. But there's great templates there, I think. So maybe I'll just close with some recommendations of, you know, if I had to do this again, what would I do differently? One is I would focus more on the results from the outset and think about, from a policy-making decision perspective, what insights are needed quickly? And how do we try and get that from researchers and from other sources like CBS and how do we get that into some central location, synthesized, and to decision makers? I think we did a good job, but I think you could do a better job probably if we thought a little, had more time and more preparation. I think we also need to spend more time communicating with researchers, the people that we funded to do studies, to improve the data quality and align the governance. And by that I mean, what needs to be in place at the outset for those researchers to be able to do what they're trying to do, which is, do really good science in the middle of a pandemic with all sorts of demands on them, but still be able to ensure that the data and the results they're producing are not just producing papers, but feeding in more rapidly to some broader process. And I think part of that is a common understanding of the value of that process. And we did work on that, but I think that could be done better. More focus on linkage, but I won't say more about that because I think that's been well described. And the last piece I'll say is this goes back again to a bit of our dual role in a pandemic. We were kind of a research funding and directing and coordination organization, but we also had this kind of monitoring role. Because we were able to be a little more agile than federal, provincial, territorial governments in standing up infrastructure around serosurveillance and generating results from that, I think it's important that that's recognized, that part of the role. And I think there needs to be some clarity around the governance, frankly, about how the role of an organization or an entity like CITF in the context of a public health emergency, and what is their role in coordinating with provincial, territorial, and federal governments around that monitoring role that is usually really squarely in the remit of governments. I'm not saying that was we had a lot of challenges there, but there were issues, and I think if that was thought through a little bit more at the outset, everybody could work together more efficiently. And I'll leave it there and pass it back to you,
David, it made me think as you were speaking about how, the standard case reporting and hospitalization data and mortality data were what provinces and territories were kind of relying on to tell them what was happening. And with the Omicron tsunami and the fact there was not PCR available, there were rapid antigen tests you could do at home, but then no reporting mechanism. They kind of lost an idea about what was happening in the population, and our seroprevalence results took on immense value for decision makers. So it's just...
Completely agree, yeah, especially during that period of the early, when the Omicron variant started to arrive, and once PCR testing, which was always biased as a measure and influenced by different factors, it became really almost not terribly useful at all. And in fact, we never really went back to using case reporting data in a meaningful way after that. Mm-hmm. So, I'm sure we could all speak about some of the challenges just with surveillance data in general. And I think that's actually a part of this issue too, is, what is the role, obviously, of serosurveillance data in some future emergency, and not seeing it independently, though. It's part of an array of other platforms like wastewater surveillance, genomic data, and the traditional indicators that we think about, like mortality, hospitalization, public health cases. But to be honest, some of those usual suspects need a bit of a refresh.
Right.
And, in terms of how we go about it, how we coordinate it across the country, and what their real value is. If you think about the amount of effort we put into case reporting, boy, was there a better thing we could have done there that would have been more, just being a bit provocative there, but was there another thing we could have done with that effort that would have been more insightful? I don't know.
We will get to the audience and get them to start answering that question in a moment, but we'll go now to Harriet to speak to us about SeroTracker and what you were seeing and your experience with that.
Hi everyone, I'm Harriet, happy to be here from Vancouver. I co-lead the SeroTracker platform along with Mairead Whelan, who's also here. We created SeroTracker in 2020 to try to unify very scattered seroprevalence data sources and create a resource for researchers and decision makers. So during the pandemic, we identified, screened, and extracted core data elements from over 4,000 published seroprevalence studies, and we pipelined these to an accessible dashboard to visualize seroprevalence globally. So while this was great, we had a pretty high functioning pipeline to translate lots of data. One challenge we saw was there was an average 5-month delay between study sampling and reporting, which obviously hindered timely results. So that's one opportunity that we see improvement for with HEMANET. So along with our partners at the Center for Health Informatics in Calgary, we're helping to develop the information technology or infrastructure component of the HEMANET network. So on that note, I wanted to speak a bit to the first and only meeting so far of the data working group in November. In this meeting, we discussed mainly different potential types of data governance systems and some of the network needs for such a system. And particularly a Canada-wide system, as is mentioned, which we don't currently have. So we first talked about a federated system for data, which is useful because each member would retain complete ownership of their data, and a central hub could still query results and run analyses on that data in a timely manner. It was pointed out by the group that this is a relatively novel system, especially in the field of public health data. It has not been developed particularly well, and there are clearly some challenges if sites have different ways that they operate and collect data. For example, different assays and cutoffs, as we know, that can have a large effect on seroprevalence estimates. So another idea proposed was more of a hybrid approach where, for example, with an emerging pathogen, we would have some initial centralized modeling where one analyst or team would be able to actually see all of the data, see what's going on. And then once processes and assays are established for that pathogen, moving into a more federated approach. And so obviously the challenge with that is that in terms of permissions, that would require some very detailed general agreements from the onset in order to make that work on the legal side. So then in terms of some of the network needs for the data system that we discussed, some of this echoes what Andrea was saying that came up in the Sero Summit data working group, and also what David said. But in terms of collecting the data, standardization and core data elements are very important. Each site needs to have the same similar variables that they're collecting and reporting. And then preparing and translating the data for analysis, which always ends up being a lot more complicated and taking longer than anticipated. So a few proposals that were discussed there to help with that. We're having dedicated staff at each site for data prep, some sort of like a full de-identification process, for example, by like shuffling the columns in the data so that the sites would be able to send the data to the central team to do some pre-processing and then could be sent back to the sites for analysis. And then finally, if agreements were in place, this is the system that we learned, members at Popcorn is used to create Excel templates with the necessary data elements, send those out to the members to fill out and have them sent back, possibly with some automation to make that easier for investigators. And then analyses would be done centrally using this information. So yeah, I think that's my time, and that's what I wanted to touch on.
Great, thank you. So we have, before we throw it to the audience, we have about 6 minutes for between the panel, and you can ask each other questions, but I want to ask David a question. What does artificial intelligence contribute to this discussion, given your experience at Mila? Can you see it advancing? Is it something we should be thinking of as we go forward planning Zero?
Just trying to think about that one. I mean, yes, I could think of a few ways it might contribute. One is certainly through the kinds of analysis you can do to integrate data. But to be honest, and there is a role there, because one of the things we worked hard on was trying to actually put together the data sources we had to understand what's the true level of infection or force of infection in the population. That's really challenging because we don't have any direct measurements. everything is indirect and biased in ways you don't fully understand. So in theory, with sufficient data, you could build machine learning models that might be helpful with that. I don't know if we really have access at this point to sufficient data. I think a more useful area is probably in knowledge synthesis, actually. And we're seeing that increasingly with large language models or foundational models now, where, you know, like ChatGPT is perhaps not the best example of that, but it's that technology where, you know, it can be used to very effectively synthesize biomedical literature and generate communication about that that's accessible to different people at different levels. So, I mean, those are a couple quick answers. I think it's interesting too to think about the way that we engage with that community though in the future around what we're trying to do, because, you know, we funded a lot of substantive research projects, but there's a lot of methodologic research too. We did fund some of that too, I think, but you know, but it'd be interesting to think about how you could rapidly mobilize that. I mean, I think in the pandemic, the AI community got very involved in a few areas, mainly around trying to drug discovery and trying to push forward some type of contact tracing analysis of that, which got into sort of privacy issues. And let's not go down that rabbit hole, but yeah, so I mean, I'd reflect on that a bit more, but those are the first two that come to mind, is some kind of a data integration analysis, and then, you know, sort of knowledge synthesis and communication are probably the two, with the technologies we have right now, that to me seem the most, like, proximal to what we'd want to do.
Anybody else? Harriet, do you want to
Yeah,
comment?
just to add on that, that's something we've started looking into. In Zero Tracker actually is using AI for literature review. So we're looking into, given prompts and inclusion, exclusion criteria, how well would a ChatGPT style model compared to our more manual? Because we have
you
a
published
lot
on
of
that. Didn't you publish an article on that was looking at, yeah.
We haven't published like an AI article yet, but we're working toward that still, like in the model building phase, I guess.
There's lots of activity in that space. There are groups that do that for systematic reviews, or trying to anyway now. But yeah.
We can throw it open to the audience. Mark, Andre. Yeah. I don't want to railroad the conversation to be only about AI, but I just think that's something that's intriguing me.
Just a follow-up to your question, Kate. How can we use AI in this space? Given the large numbers of samples we analyzed, we started using machine learning to make the calls for seroprevalence. Given that we had cohorts, calibration cohorts from the NML, we had all the samples coming in. So we actually ran all our samples through machine learning algorithms to make the seroprevalence calls. And that's very useful when you have an antigen with some cross-reactivity to seasonal coronaviruses and early infections where the spike is going up but not so much. The machine learning actually was able to slightly more accurately make the seroprevalence calls than what we do with standard cutoffs. So that is one example of where we've already applied this.
Okay, thank you, Marc-André. How about the challenges to linkages? I mean, Sheila's told us some of them sound like they're a little bit legal, but I mean, how much is there in terms of turf and ownership, and how much? What are the issues around linkages? Because this makes no sense. We have no joined up system in Canada. It's crazy. Do you want to comment? You've been dealing with the legal part.
Yes, more than just the legal part. I think there's, when you get into what the challenges are, I think it's a common understanding of what it is we're trying to do. There are issues around ownership, so that's, that is a big thing. Who is responsible for the custody of that data, and those things are not easily resolved. I mean, I think it takes quite a bit of discussion about a lot of restructuring of how one thinks to do that. So for example, in Ontario, there is a legal structure that will allow the sharing of the data, but it's fairly confined. So you can't just make it available to everybody once like our IDAV portal, it's only a very limited number of people that can access it, and they all have to sign agreements before they can access it, etc. So it's taking care of the privacy, but it's also, it's not our data, it's belongs to Ontario.
I was quite excited by Agatha's presentation. Sometimes you can really make things happen. So Laurie, I wanted to ask you, with what you've got, so you have age, the forward sortation area, and the serology results. Can you look at like the Revenue Canada database, the Statistics Canada database, on material deprivation by postal code, by the can you do other analyses with what you've got that could be interesting, even though you don't have the information you'd like to have? Can you match to other databases?
Yeah, and certainly that's something that we started to do even as we sent data along to the team in BC who was doing the overall data synthesis. When we started looking at, okay, well, what does this mean actually in the Nova Scotia context? Then some of those other databases, we did start to go, where I started to go and look at to say, okay, well, what has already been reported about Nova Scotia in terms of what's already being seen and how does our data compare? But yeah, to be honest, we hadn't moved any further in terms of, what, based on these postal codes that we have, what are we allowed to link into that? Mostly because we would need to adjust our REB to do that. Totally worth doing, just hadn't reached the level of, yeah, we're going to spend time on that.
Okay, just a question. Other questions, audience? Yes, at the mic, go ahead.
I have a question regarding standardization of, I guess, data terminology. You talked about trying to come up with, common data fields to collect, during the course of this pandemic. But is there any work, underway or maybe already done that maybe looks at sort of, generating ontologies to be able to, standardize terms from data sets that already have been collected in the past that haven't been standardized at the time of collection? Is there any way to try and harmonize them now? And sort of a bit on a related note, given that some of the data fields that we collect, they do relate to definitions, case definitions and such that change over time. Is there a way to track the changes in the case definition and to ensure that those linkages and and our definitions remain current?
That might be a question for you, David.
I love to hear the word. I wasn't expecting to hear the word ontology, so I'm very happy to hear that, which is just a well-structured taxonomy, by the way, but that is computable usually. So to your question, yes, we did do a pretty careful review of what others were using. So we looked at the US, we looked internationally for these different data elements and worked with our experts in the panel to come up with the elements. And then we versioned them. So we did actually have a proper versioning as we adapted and evaluated, it's changed essentially, so that we would have very clear sort of history of how things had changed over time, which was really critical for the harmonization process that we did. And so I didn't talk about that, but we worked with a group, Isabelle Fortier and a group who have a lot of experience in this space in harmonization. What harmonization means is even though we ask everybody to collect data in the same way, for either they didn't understand or they had a good reason to do it differently, they did it differently. And so in the day, we have back now, so we're on the order of around 60 to 70 data sharing agreements. We're bringing in these data sets. We currently have 20 of them harmonized. We have 30-something individual data sets, but 20 of them harmonized. And what that means is that we've gone through every variable and every data set, check to make sure with the study team that they're actually using the term in the way we expect them to use, not just they encoded it the same way, but conceptually it means the same thing. If not, we have to make changes with the understanding of the investigator to align these different questions. And where they can't be aligned, we don't try to align them because they're not measuring the same thing. So a good example is somebody reports blood pressure, another person reports supine or lying blood pressure, another reports standing. These can be different things, but you just want to be clear about that. So that's a very complex process, but at the end of the day, we do that harmonization. People can now download with appropriate approvals from us a data set with 20 different studies in it, individual level records, where they can literally load that right into an analysis package and do analysis because they know that the variables have been harmonized. And so it's a great question, and it takes a lot of work, but the added value for research at the end of the day is, I think, very large because people really understand what the data means.
And just to qualify, there's a whole approvals process. You present your proposal, it's reviewed by a committee,
Yeah.
and
Yes, of course, yeah. So under our data governance framework, you can't just download those individual records. You have to go through an independent arm's-length data access committee and present a valid protocol, RAB approval, and then sign a data sharing agreement with McGill to ensure you'll maintain those data under the same safeguards as we do here.
Tim.
Yeah, great, thanks. Terrific panel. There was a comment this morning that I just wanted to bring back that somebody mentioned, and I can't remember exactly who, but apologies, but it says we need to have agreed language for broad informed consent. And I was just wondering if people on the panel might want to talk about the opportunity of changing informed consents across the board so that there's an opportunity to manage that in such a way that public health needs can have more access to that data, and obviously in responsible ways. But I sort of have the sense that the system is mostly protecting individuals to such a degree with respect to information that it may be very, very difficult to get that the data linkages. So that's one question. The second is it looks as if the nuts and bolts of data linkage and navigating sort of the management of complex data sets with variables coming from different places is not straightforward. How well are we training people to manage complex data sets? We're good at generation of data, but are we missing perhaps that sort of management of as an important part on the capacity side? We need to think about. Last is I'm struck by the fact that I think it's only one province that's taken advantage of the federal-provincial transfer because the Fed said you only get the money if you're going to report. Is there a way that we can take advantage of the provinces not wanting any of that money to say that as part of the deal, we need to have some clarity on perhaps, following in the CBS lead, that we create data linkages so that the expectations on what would constitute availability of data would allow us to perhaps transcend some of these provincial dichotomies that are limiting opportunities to make connections between different sources and pools of data. So I'm just thinking if HEMANET came out in the next couple of months and said, these would be really very important things to see in provincial agreements, building on some precedent that those have already been moving in some provinces. Could that be something the feds like, because it'll delay the likelihood that those agreements will ever be made?
Okay, I'm going to take the chair's prerogative to move your ethics question to the next session, because we're going to be talking about privacy and consent and so on. I'm going to ask Harriet to comment on the capacity strengthening. Where's the next generation of data scientists coming from, and how do we get there? How should we be supporting them?
Yeah, that's a great question. I think we definitely need more training. From what I've seen, even with our limited hiring for our own team, it's difficult to find. It's sometimes easier to find people with like strong statistical analysis skills, but difficult that they really have also the messy data experience and ability to really just dig in and work through complex data sets. So that's my perspective. If you agree or...
And should public health schools be doing more of this? I mean, do you see it as departments of statistics, or do you see it more than just
Yeah,
the
I mean,
technical?
because I personally trained more in a pure statistics, so I also picked up that stuff more on the job or in various jobs. So I can't really comment on the public health part, but I think potentially, yes.
I saw, oh, Varun, is there somebody online that wants to? Oh, Lori, sorry. Lori, go ahead.
Oh, good. I was just going to ask my fellow panelists if they already know, are we already using LOINC codes for some of this health data?
We use Link to identify the assays within our assay inventory for this project. But I mean, I think the use of LOINC, which is a standard terminology for laboratory data, is heterogeneous across the country, I would say.
That's not helpful.
No. So I was kind of thinking like if we can, if LOINC is useful to us for the laboratory data or a version thereof as we expand on what other elements we might be calling what. It's pretty robust in terms of the interoperability then and what can trend together and what can't. And it potentially allows your systems to be able to recognize without human intervention what's an equivalent data package and what's not. We're in the unenviable position in Nova Scotia right now of trying to get all of our LOINC data in for a province-wide laboratory information system. And it's going to be worth it, but it's painful right now. So if I could build something from scratch, I would love to have that standardized piece built right in, like baked in.
Excellent idea.
Oh, can I just add in?
Yes, go ahead.
Yes, on the training piece, it really depends on, it's very program specific, first of all. So you can have people trained, but for the system that you're using, you might not be able to find people. So, and a lot of the skills that one has to develop over a very extended period of time with a lot of repetition. So for example, if you want to hire a SAS programmer who's an expert in statistics and can manage a complex database, they will need at least 10 years experience. So even whatever your training is in the university, you have to have the opportunities to learn in other environments. And I think that's kind of like, we have to have that continuity there.
Okay, Alton and then Stephen.
Thanks. Yeah, so it strikes me that like none of these problems of data linkage and timeliness are really unique to what we're doing. And I think even in the case of transfusion or blood donor data and transfusion recipient data, like there's all types of needs for vein-to-vein research, of issues of alloimmunization. So I'm curious the extent to which we are successfully or we need to improve on kind of like bringing the people who have these same data pain points together so that we can kind of create, I've even imagined, we have a common lease template in Quebec. We have common data use agreement templates where it doesn't have to go through, every line doesn't have to be scrutinized by legal every time. Like, are there opportunities that we're not realizing, even with an organization like CBS, who's doing both this public health research and wants to be doing more of this kind of transfusion safety research to kind of do those, to basically, to work together on the pieces that are common, I guess. Are we taking advantage of that to the extent that we could?
We do have the Canadian Transfusion Trials Group as well, which CBS is a supporter of. They are interested in setting up transfusion-related clinical trials and are looking at a proposal for a data structure. The laboratory data is really complex in transfusion because every system is different, and you have to be you're trying to get from the operator to the hospital, and it's all over the place. So that's one of the issues that they have to deal with. There's probably will be able to do it with certain hospitals, but not all, at least initially. As to whether or not all the players are in the room, I think that is the thing. The next meeting that we will have, we will bring together a variety of speakers to try and look at the data structures, the data issues, and linkage. But it's still kind of, it's in its infancy.
But I also got the idea of, Alton, you're talking about having these agreements in place and before anything hits us. So it's sort of, trying to anticipate. let's keep that. Okay, Stephen.
So this may be more of a Sheila question, but the holy grail for data linkage is ScanDat. And it does exist out there, but I'm not sure we can ever get to ScanDat. I was wondering if you could tell us maybe what ScanDat was,
Yes.
whether we could, what can we learn from them? And we're obviously may not be able to get there, but it's already built. So maybe we should be going top down and figuring out what to do.
Yeah, well, ScanDat's awesome. So in Sweden and Denmark, they have linked their data from all blood donors to all transfusion recipients. So it's fully linked within the healthcare system. When you're born in Scandinavian countries, you get a number, and all of your healthcare is linked on that number. So it's they have really complete data there. But ScanDat are able to ask questions about, so donors with this particular background and their blood went to particular recipients, are they seeing any increase in any kind of unusual outcome? It's very good. It also can lead to some red herrings where you end up seeing a correlation, but it's not real, or it's very small. So, but overall, it's an excellent program. What they do, they don't have Sweden and Denmark together. Sweden have their own, which is out of Karolinska University, and they manage the Swedish, and then the Danish one is managed separately, and sometimes sort of like what we're planning between BC and Ontario, and sometimes they do the same analysis on the two sets and they combine them.
I think we have to move to the next panel, but thank you so much. Thank you, Lori. Do stay on because we'll get into consent. Thank you.